Let's
Hey
do it.
everybody, this is Travis Robbins at Robbins Rehabilitation West. I'm here with Dr. Wairi Aruru, and he is a new doc that we have. I don't know if I can't technically call you on staff, but we feel like you're on staff because we feel really close to you. So he's going to start doing some office hours in our office to try to help out our patients, in physical therapy. A lot of times we're treating pain. And Dr. Aruru is going to talk about things that he does in terms of helping patients with pain. But first, we want to learn a little bit more about him. So tell us your story, Doc.
Yeah, absolutely, Travis. Thank you very much for the opportunity to really get to talk to you and your patients today. It's been a very fun journey for me from going to medical school in Minnesota. Really, medicine has been a passion, and I enjoy interacting with people. I enjoy the process of diagnosing, treating, working with colleagues, thinking about the body more than just the body, but as a whole person. And that's really something that really fascinated and drew me to medicine. So, I did my medical school at Mayo Clinic at Minnesota, and I did most of my postgraduate training, master's, surgical residency, fellowship at Boston, and made my way over to Pennsylvania, where I've served at the University of Pittsburgh, and also now currently run my own private practice in the Lehigh Valley. So really what has been intriguing and just fascinating with just the medical practice itself is really that patient-doctor relationship, and I get to do that a lot with pain management, and it's been really fun, and I'm looking forward to this conversation.
Yeah, when people have pain, I mean, I've been doing this for 25 years now, and I've had bouts of low back pain for sure. I've herniated disc in my low back, and when you have back pain, I mean, there's really nothing else you can think about. Like you can't think about your kids or your family or work or anything else until you get rid of that pain. So that's what I've kind of spent, the last 25 years helping people figure out, and working with other practitioners like you to try to get people out of back pain. I know what it's like to have terrible back pain, and I don't want anybody to have that. So, just getting right into that. I mean, a lot of what we see as an ortho outpatient clinic is backs, knees, and shoulders. Those are the areas of the body that kind of wear down as you get older, but also can get injured when you're younger as well. So, when someone is coming to you for back pain, what are the most common reasons that someone ends up on your table that has back and neck pain?
And quite frankly, that's a great question. And it varies with age. When you're younger, it's a lot more related to being athletic or being in something that could have provoked your body to have worked a little bit harder than it's supposed to. And when that's the case, whether it's playing sports, whether it's, just from a stationary activities like driving for a long period of time. But the idea usually is when you're younger, some of the things that can provoke back pain tends to be related to activities, and very common we would see um, patients come in with like a disc herniation from maybe a high impact event, whether it's an accident, whether it's playing sports, or whether it's even sitting for a long period of time and you go for that wrong twist at the wrong angle and the body just had a hard time adjusting to that change in motion. So, you can see that a lot, like a disc herniation. And then as we get older, you can see multiple reasons that can contribute to one of the reasons why patients come to me to manage your pain, from arthritis, which is inflammation and, at just ridiculous spots in the body. The problem with arthritis, you get close to a nerve, it gets very, very angry. And we see that a lot. And middle age, older age, and even quite frankly, from genetic exposure, you can see it in younger patients. So arthritis is very common. Sciatica, which is a very common thing that people talk about, is another common reason why when I see patients for back pain, they need assistance with, or neuropathy, that the nerve is just so angry and they have no idea if it's from their diabetes, if it's from something that mom and dad passed on to them unluckily. So there's really multiple slew of reasons patients come to me, sometimes even come to me with pain after surgery. So they've had surgery 5 years ago, 6 years ago, and they still have pain. And the question is, I thought it was fixed. Why does it still hurt? And again, it becomes really fun because we get to go through this journey together to figure out the etiology and then parse out how to really help patients. So yeah, so those are some of the common reasons.
Okay. And most people, when they get back pain, they're not like, oh yeah, I'm just going to go right in and see the doc. They're kind of like, well, kind of hope it goes away. Maybe if I wait a couple of days, well, I'll just eat a bunch of Advil and try some ice packs and some hot packs, hope that it goes away. But what are some things that you can tell somebody, or some advice you would give somebody to be like, if you're having back pain, it's okay to maybe wait a couple days to see if it's going to get better, or it's something you should immediately get seen by a specialist like us?
No, absolutely. I think, back pain is like a story, and I tell a lot of my patients what's critical when you when you hear a story is you have to listen, and it's critical. So some of the red flags that I would say should prompt not just even getting a specialist, but going to the ER, for example, is you have pain and you can't really move your legs or you can't move your arms, and it's really brand new, never happened before. A lot of those are very, very urgent situation that requires kind of like a very time sensitive response. However, and then thank goodness, most of the pain that we see do not actually fall under that category. Most of the pain that we see are the ones where you have pain, you can't really explain why. It's numbness, it's tingling. You turn to the left, it hurts, or you wake up in the morning and your neck feels really stiff and you can't really turn it. When you get into scenarios where you have pain and it's pretty early in the journey, what you listen for is, can I actually try to help myself with improving the pain by working with, and I'm going to start with some of the things that patients would do. They could take over the counter medications. One of the things I always recommend is talk to a physical therapist. Okay, make sure you understand the ergonomics of your body. Recognize that your motion and your the structure of how you sit, how you actually sleep sometimes can impact your pain, and recognizing that movement and adjusting the nerves, the muscles, the joints at the areas where your pain is located can actually result to significant improvement. So I usually say, I tell a lot of patients, when you have pain, you can exhaust over the counter medication, but one of the other things you have to do is talk to a physical therapist. Physical therapy, physiotherapy, and rehabilitation, it stands the test of time. I tell a lot of my patients, it's so powerful with physical therapy and rehab that patients who actually have stroke, which means that there's issues wrong with the brain, they go through so much rehab and movement, because moving itself, it's almost like retraining the nerves, the wiring in your brain to start firing like normal. So when you think about it, pain is just not any different. So a lot of times it's physical therapy, and then when you've exhausted so many options and it's not working, you've tried everything that you can, whether it's over the counter, you've worked with your physical therapist, you've tried other conservative care, TENS units, massage therapy, and it still hurts, then it may not be a bad idea to seek medical attention with like an interventional pain doctor. And what I could do at that point is really obtain like maybe an MRI or a picture of the back, something to help diagnose why your pain still persists despite all of these treatments. And again, obviously, there's a spectrum that goes all the way to even an intervention that could be surgical. But again, what I would say is some of the things patients can do that pertains to managing your pain prior to regardless of what the degree of symptoms are, is you can try conservative measures, over the counter medications, Tylenol, ibuprofen, heating pad, warm compress, cold compress, TENS units. And if you don't feel like you're getting any better, I always say, under the guidance of a healthcare provider, you should definitely consult with a physical therapist who can actually help you understand why you're in pain, as it pertains to a lot of things about your body's anatomy and physiology you're not aware of. And then the other thing I would also say is, as the pain continues to persist despite your ability to perform all this conservative management and it's still there, it's not a bad idea to consult with an interventional pain specialist.
Yeah, so we try, you're on the same page as us. We try conservative measures. We want to exhaust those first before we go to more aggressive treatments, but it does happen. We say, I'm biased. I'm a physical therapist. I think I can fix anything when I get in the room, and I can't. There's a certain percentage of people. It's like we tried what typically works with this, and it's not responding, or it's getting worse. So that's why we're excited to have you. So in that situation where first we're going to go conservative, and we've kind of gone through the 6 or 8 visits, it's not going in the course that we typically see it if the patient's going to recover, and we send them to you, what what is treatment gonna look like? And what are common things that people would expect when they have an appointment with you?
Absolutely, that's a great question. So first, I say, like I say, the story about pain management really comes down to listening. And one of the things my patients will tell you about our interaction is, I like to hear why it happened, how it happened, and I want to learn about you too, because pain could be from multiple etiology, whether it's from what you do at home, from how you play with the kids, and from just several things that make up who you are as a person. I really take the time to understand that. Now, recognizing that your environment really could be implicated in the etiology of your pain, one of the things that I also take the time to do after obtaining very thorough history and physical exam is to really discuss why you're in pain. And that could require getting an MRI, could require diagnostic tests like an X-ray. Let's take a look at the bones. Get an MRI. Let's take a look at the nerves. Is something pinching on the nerves? And sometimes we may even be specific to do like an EMG where we can obtain sensitive and sometimes specific information regarding how your nerves should work. Now, when all of that information is gathered during the visit, the history, the physical exam, the diagnostic test, it is my job to come up with, hey, here are some of the possibilities that can explain why you're in pain. And the reason why that becomes really critical is because depending on the reason why a patient could be in pain, we could offer things as simple as, again, go back to physical therapy. I think your body looks good structurally. You just really need to go through the motion of strengthening your core, ensuring that your posture is in place, ensuring that the joints are in place. So, really, we can either say go back to physical therapy, or sometimes we can recommend medications to help with the pain. If it's a nerve related pain, you can prescribe nerve related medication. And even further down the line, we can recommend like cortisone shot. A lot of people talk about shots, and that shot can be so many things from immunization shot to an actual advanced spinal shot, which can help with your pain, and even go as far as minimally invasive procedures that can help disrupt that spiraling cycle of the pain. So it's a plethora of options that we offer patients, but the visit usually typically looks like an interaction, getting to know the patient, listen to the problem, understand the problem, diagnose the problem, and then treat the problem.
So, what are some common things that, if they patients fail conservative care, they end up going to you? Hey, let's get an X-ray and MRI, get some more pictures, and then you get the diagnostics. And you're like, oh, that's what's causing the problem. What are common things that might be causing the problem? And then also talk about specific to injections. We get a lot of questions about injections. We try to avoid injections, but sometimes the patient needs it just to like get inflammation off a really hot nerve because we can't get anywhere in therapy, or they're just not responding the way that we want them to. Talk about some cases that you've seen in the past that have benefited from what the protocol you're talking about, getting some diagnostics. Okay, we actually see the problem, and then what is the intervention?
Absolutely. So very common things that we see in a pain clinic is pertaining more to like a disc herniation. A patient comes in and they're like, my back hurts and it shoots down my leg. It hurts so bad. Nothing takes the pain away. It is so annoying. Just can you stop this pain? Very so often after obtaining an MRI, you can easily identify that there is a disc bulge, and a disc is kind of like a cushion between a stack of blocks in your spine that makes up your backbone itself. And when it moves out of place, the spine is really surrounded by a bunch of really important structures like the nerve. And when that disc bulge begins to push on the nerve, it could be a source of that annoying back pain shooting down the leg. So in cases like that, we can do a cortisone injection. And the goal of the cortisone injection is to really reduce the inflammatory response that the body has acted upon based on that injury. And by doing that, you can actually calm down the nerves and improve the symptoms and also mitigate the pain. Another thing that we do is facet injection. The facet are small joints in the lower back that actually have small spaces. Now, what I tell a lot of patients is anything that has a space in your back can really hide stuff. And when it hides inflammation and there's a nerve traveling around that space that it's hiding, it could be a source of pain. The facet joint is just another classic space in the lower back that can be that can be really filled up with inflammation. So patients who have arthritis can have a lot of arthritis in that small joint, and that joint becomes a source of pain. Well, guess what? We can use an X-ray to find the joint, put medicine around it like steroid injection, or sometimes we can even apply heat. And the very common term for that procedure is called ablation. So I'm sure if you've heard your family members say ablation, that's really what they're talking about, where you find those little joints and apply heat. And what the heat does is eliminate the nerve coming from that joint. Now, another common procedure that we actually do, in addition to just the shots and the facet blocks or using heat to eliminate nerves that causes pain, is really minimally invasive procedures. So I tell patients there is a lot of options between injections and then getting cut open to get rods and screws. I'm not saying it's bad to have rods and screws, but there's so many options between that cutting open to get rods and screws and injections. And those things can vary from very, very minimally invasive procedures that can actually target specific nerves, modulate the nerves so they no longer, so your body no longer perceives pain. We call those procedures stimulators. There's so many other things we can do for spinal stenosis. Instead of having the bones peeled open and getting a big surgery, you can just scrape up a piece of the lower back that's causing the problem. And these are like almost no incision, and it's insane how much we can accomplish some of these therapies. So, in short, the things we offer can vary from injections, cortisone injections in the back, cortisone injections in the knee and the shoulders, to even performing more advanced procedures like applying heat. It's also called ablation around nerves that are causing pain. That can be done in the knees as well, the lower back, the shoulder, and again, a lot of minimally invasive procedures that don't require and like a big open spinal surgery.
So talking about lots of different procedures, we run into this a ton, and I'm sure you're going to automatically recognize this, but we'll have patients that come and say, I don't know why I'm here. I had physical therapy. It didn't work. And we'll say, well, tell me about physical therapy. What happened? I don't know. Some kid put me on a bike. They gave me like a sheet of exercises. I did some stretches. I had a $40 copay and I wasn't getting any better. So I didn't keep going. I was like, yeah, I wouldn't keep going either if that's what physical therapy was. So we see a lot of second and third and fourth opinion and stuff. And it sounds like you see that too. I mean, just the most immediate things for us are, were the joints mobilized or manipulated? Was the nervous system addressed? Like, did anybody do any nerve tension testing on it? Did they treat the nerve tension issues that they have? And then as soon as we start talking, it's becomes clear they may have had like a more basic form of physical therapy. So we're like, okay, I know you got burned, you didn't have great physical therapy before. Just give us a shot because we want to try to exhaust conservative measures. So now for you, what are common things that people are watching this is that I went to pain management, I went to my doctor, they did this and it didn't get any better. I'm just going to have back pain forever. So, what are common things that you see in that area?
I would say it's not unusual for patients to come over to the clinic and mention exactly what you've just said that you see on the physical therapy side. Oh, I've seen so many pain doctors. Oh, I've had pills. Oh, I've had so many things, and it still doesn't work. Here's what I always tell patients: what is your diagnosis? And it's a very critical question because recognizing and understanding your diagnosis is instrumental to the kind of therapy that will help you become better. So one of the things that I always say is, make sure you know your diagnosis, and there is never one stop solution to pain management. It is a multidisciplinary approach. And even when they get shots, I always encourage them to go back to physical therapy, because if the core is weak, and your nerves are released, well, guess what? It's going to collapse backwards if you don't keep working at it. So, very so often, some of the things that I see from patients that come in from being frustrated from other pain physicians is that they've tried multiple shots, they've tried multiple medications, they've even had surgeries, and yet they have no idea what's wrong with them. And what becomes really critical is really trying to parse that out, because when you take the time to recognize and understand why it hurts, then there begins to be this plethora of recognition that it's going to take a village. It's going to take multiple options to approach this problem, because it's not just that the left straw is broken. There's just more to why you're in pain, and that's where we make a difference. So very common we see those frustration, but it just goes back down to recognizing and diagnosing appropriately, as well as selecting the therapy that matches the problem.
So you talked about you've seen patients that have had surgery and said, "What's going on? I still have pain. Like the surgery was supposed to be the fix." We always tell patients there's no guarantees in surgery. As soon as you cut somebody open, we've seen amazing recoveries and incredible spine surgeries, and we've seen one that haven't gone that well. Same thing with joint replacements. I think maybe that's the most frustrating because our patients will get a joint replacement. They've heard from their neighbor, "Oh, I had terrible pain, and now I can do whatever I want." And then they have a joint replacement, and then it doesn't go the way that they were expecting. Is there treatment for that? Or is it, hey, man, we did the joint replacement. There's not much I can do. You're kind of stuck with it. Talk about patients that you see after surgery.
Absolutely. And one of the things I always tell patients, when you have pain after surgery, it does not always mean the surgical procedure has failed. The body goes through neuroplasticity, so the nerves relearn the structure, the joints, the new metal, or sometimes parts of your body could be removed so that you actually get relief from the symptoms. The body has a new state, a new anatomy, a new physiology to interact and work with. So, what I always tell patients is when you have pain and symptoms after surgery, like numbness, tingling, sometimes it's restriction in motion, where the function is impaired. It doesn't always correlate that the surgery went wrong. It could just require that there's other aspects that needs to be treated and managed after surgical procedures. Very often, I'll tell you, when patients have back surgery and they still have pain, there is a condition called persistent spinal pain syndrome. And it doesn't mean that the surgeon did not do a good job, but it just means that there is just a bunch of wiring in the lower back that you're going to have to help after surgery so that the patients can actually get better in due time. And it's one of the reasons why, even after you get certain kinds of back surgery, it takes about a year. The surgeon will tell you it takes about a year for you to really get back to where you are, and it's going to take physical therapy, it's going to take pain management. So we see a lot of patients that come in with pain after back surgery. Another thing that could work in scenarios like that is we actually target the nerves that are angry after, post surgically, and we try to deaden those nerves. We try to retrain those nerves, whether it's using a stimulator, whether it's using heat to eliminate the nerves. And those nerves are very smart because they grow back. But what's nice is then patients can function and the symptoms can be better. The same thing applies to the knees. Patients come in and they have persistent pain after like a total knee replacement or a shoulder surgery. It doesn't mean it's a failed procedure. If the procedure has failed, obviously you want to talk to your surgeon and get more advice on how to manage it, maybe a revision. But if the surgery was successful and it still hurts, it's not unusual to have neuropathy, to have neuralgia or very painful, angry nerves around the area where you had the operation. And when you come to pain management, one of the things that we do, our job is to isolate those nerves and again, directly treat, mitigate the pain so you can actually function, and even in most cases go back to physical therapy so that your body can actually learn how to work with the new adjustments to your anatomy. So I hope that answers your question, but there's just so many options. Persistent spinal surgery is one of the things that we see after back surgery. We also see CRPS, which is called complex regional pain syndrome. Usually, there's a region of the body that is affected, whether it's the knee, the ankle, the shoulder. It is not unusual. And again, you may even have neuropathy after injury during surgical procedures. And injury in this case doesn't mean that it's a bad practice. It's just that surgery by itself is injury to the body. And in the process of healing afterwards, you can develop neuropathy, and that's very common. And we have several things to help manage those presentations.
So we have patients, and again, they kind of sometimes associate surgery with fix. I try to push them away from that thought, but some people just do that, and they'll say, "I need to go see an orthopod that does surgery." And we err more on the side of exhausting conservative measures. So for someone that says, "Why would I come see you? I got to go see a surgeon. I know I need shoulder surgery." What can you tell them to help them maybe make a better decision?
So, that's a great question. And there are medical reasons where surgery is imperative. You have to get surgery done. And I will tell you, those reasons are very far and few in between. And they're very clear for the most part. However, for a majority of cases that are not surgical, what I tell patients is exhaust every non-surgical option. Okay. And the reason why that's critical is I still think the body is one of the most beautiful made machine that's ever existed in planet Earth, because when you give your body time to heal in situations that are non-surgical, your body will respond. It may take you time, it may take diet modification, it may take understanding nutrition, physical therapy, it may actually require just how you sit down at work or how you sleep on the left side of your pillow. And there's just so much you can do, but you have to work with an expert, a professional, and people that have studied how your body reacts to pain. And if you've exhausted every option from physical therapy, ergonomics, nutrition, sleep, and even managing your stress levels, and then you add pain management procedures that can actually minimally invasively eliminate the pain. If you've exhausted every option, then yes, sure, you want to talk to a surgeon. But what I tell most patients, the options you exhaust is dependent on who you work with. So I strongly recommend that you work with a very knowledgeable provider that understands the options that are available to you to manage your pain, whether it's naturopathic, whether it's conservative care, whether it's physical therapy, whether it's interventional pain management. Know the options that you have to manage your pain. And if all options are exhausted, by all means, if you're still having discomfort that affects your function, your sleep, your mood, by all means, I think it's not a bad idea to talk to a surgeon. So the summary of my, it's a long answer, but the summary is really you have to exhaust conservative options before thinking of exploring surgical interventions.
And we talked a lot about spine. So, common things like you said, if you have really severe arthritis and we do physical therapy, sometimes it will get worse or it certainly won't get better. Same thing with a disc herniation. We try as best we can to handle that conservatively, but a lot of times we have to refer that out. Let's talk more about shoulders and knees.
Yes.
So, patients that we have that have probably some similar things, severe arthritis or some kind of maybe a structural issue, what are the common things that you see? But when we see them for physical therapy, you're like, hey, doc, we tried our best for 6 visits. It's not getting any better. Let me, you take a look at it and see what you see. What are common things or issues in the shoulders and the knees that are hard to overcome in conservative physical therapy?
Absolutely. That's such a great question because the joints are very interesting because they tend to like carry stuff in and they're very isolated. So one of the things that I tell patients that is very common, especially joint spaces like the shoulders, the hip, and the knee, those spaces are pockets. And they had the shoulder, for example, has a lot of pockets. And like just like the spine, when you have a pocket, you can fill it up with something. So during a state where the shoulder is injured, you have a lot of inflammation accumulating in those pockets. Again, the generic term is arthritis. So that presence of inflammation in a pocket in the shoulder, say for example, there's a bursa in the shoulder called the subacromial bursa. Sounds very fancy, but it's just a space in the shoulder that when it gets very inflamed, that pocket can be a source of pain. So very commonly, you can see arthritic presentations. You can also see structural problems like a tear in ligaments or tendons or cartilages that are connecting spaces together, and not just any space, but vital spaces. And it's not uncommon when you see those, we can offer treatment options. And one of the things that we do is very similar to the spine. If it's an arthritis or an inflammatory process, you can actually inject steroids. There are a lot of patients that lean more towards a stem cell regenerative approach, which I think is very controversial, but also very efficacious when you work with the right provider. I've been very fortunate to sit as an editor for one of our stem cell journals in pain management. But instead of injecting steroids in the joints, you can utilize things like PRP, like platelet-rich plasma, and it's taking advantage of your body the healing parts that your body creates every time and using it to actually heal those joints. You can utilize it in the shoulder, the hips, the knee. So the moral of the story is for inflammatory responses, you can treat with steroids. You can also treat them with PRP. The beauty is that when you use stem cell products like PRP, you can actually regenerate and also enhance structural components of the joints. The other thing you can also see is nerve related problems in the joints. The joints are surrounded by nerves, the shoulders, the knees, the hip. So, very similar technique that we use in the back is we can isolate the nerves and try to deaden the nerves or at least reduce their sensory function, and that can help with pain.
So we get a lot of questions about injections. You talked about it a little bit there. Let's just go over that. Patients will ask me, well, what are the negative side effects of injections? Is it going to hurt? If we stick a needle into your body, it's probably going to hurt you a little bit. The positive side effects, hopefully, is it gets rid of the pain. But what are some negative side effects? And talk a little bit more about um, the patient population that you choose in terms of, okay, this is going on in the shoulder or the knee. I think you're going to respond better to a steroid, or you're going to respond better to PRP or stem cell, or is it like a progression of, well, let's try the steroid first, and if that doesn't work, then go to the PRP, or what's the decision making process?
Absolutely. Now, when it comes to trying to decide, first let's start with complications. Now, here's what I always tell patients, and if you are not thinking about complications when you walk into a doctor's office, you're entrusting that the physician will do what's right for you, and I think that's a good approach. But I always tell patients that everything we offer in medicine is like poison, and it's kind of like a question of recognizing and understanding it. And it goes back to what we do every day. If you eat too much, you gain weight. If you drink too much, it can hurt the liver. If you take too much ibuprofen, it can literally hurt your kidneys. If you take too much Tylenol, it can hurt the liver. So too much of everything is bad. That's the pattern. And the same thing applies to injections. When steroids are inappropriately utilized, for example, if a dose of steroid that is administered to a patient is not monitored, yes, it would result to a lot of side effects, such as weakening of the bone, the joint, the ligament, and that could be a serious problem. Say, for example, you can see it in patients with osteoporosis where the bones are weakened. Now, again, it's very critical to be very careful to say steroid is the cause. It is inappropriate use of the medication that can result to some of the side effects that we see in patients. The other thing I always tell patients is it comes down to think about your provider or your pain doctor as a chef. And if your pain doctor is a good chef, you're going to expect that he cooks the best meal and you're going to go back for dinner one day or another day or a couple months from now. But the reason why I say that is that it's very important to recognize and actually ask questions to your pain physician, because the technical knowledge and skill set is critical, because with appropriate understanding, you can minimize a lot of the complication and most likely eliminate most of the complication that comes with doing the procedure, which can vary from numbness, tingling. But again, these complication rates they're less than 1% in the space, and even less than 0.08% in a few instances. So that's what I would have to say with the complications. Now, moving to the use of regenerative medicine versus steroid, that's a fascinating topic, extremely fascinating, and we can spend hours talking about it. And the reason why I say that is because the body has an inherent capacity to heal itself, and it's so powerful. What PRP means, platelet-rich plasma, is the idea that you are isolating parts of your body, parts of your blood, I apologize, that actually is responsible for healing. You're concentrating that amount and you're putting it in a body part that requires more aggressive healing. Now, one of the things I tell patients is like it's almost like when you cut your hair, it grows back. One of the reasons why it grows back is that there are a bunch of cells that make it to that location to actually see the hair grow back. PRP is very similar in the sense that you have accumulation of regenerative cells that if you pull them together and put them in a location that requires regeneration, you can actually help that body part regenerate. Now, there's several forms of regenerative formulas that people may have heard out there. There's PRP, and sometimes there's PRP added to alpha 2 microglobulin. There's even like harvesting the marrow itself. The bone marrow is kind of like I call it like the house and the foundation for all stem cells. You can harvest the bone marrow, spin it, isolate the bone marrow, and the concentrate from the bone marrow can also be used to be applied to like joint spaces, that can help with healing. Now, deciding whether you want to go with regenerative medicine versus a steroidal approach, it becomes a very, very dense but also controversial question. But I always tell patients it comes down to your what your objectives are, what your goals are. So if you're in so much pain and you want almost immediate relief, I would tell you, when you look at PRP versus steroids, PRP takes a little bit more time for you to get that relief that you're looking for. It comes with structural component, but it takes time versus steroids. You may even have relief right away or even in 2 weeks. So again, there is that part to really think about. Now, the other thing that decides whether you go with PRP or not, or steroids, really comes down to the nature of your injury. I will say that there are certain kinds of injury that I tell patients, it's probably not a good idea to spend a lot of money with regenerative medicine. And I'll give you an example is I've had multiple patients come up to me, partly because they're familiar with some of my work with stem cells, and they say, I have knee pain. I really want that PRP you published. And I look at it, I get an X-ray, and the knee is bone on bone. I'm like, it's already bone on bone. There's no cartilage to regenerate. At that point, I would discuss, use of maybe gel shots or even talking to a surgeon, because at that point you need a new knee. So the nature of the injury also determines whether you pursue PRP or regenerative medicine versus a steroid injection. We can talk for hours, but I'll leave it at that for now. I get really excited with regenerative medicine.
Yeah. Okay, so last question about pain management. What kind of appointment is someone going to have when they come see you? I mean, we've talked a lot and we've gotten a really good idea of how you treat patients, but what makes you different than other doctors that patients can go to?
No, that's a great question, and I always go back to the reason why I pursued medicine, and it comes down to really having a passion to listen to the patient's story. And I tell a lot of my patients, you actually bring the answers to me, because if I don't listen to you, I can't figure out what the answer to the problem is. And what makes us really unique, or what makes me unique in my practice, as well as my colleagues who my patients would meet as well, and the staffs is, and I see this with you as well, Travis, is really the patient story. We take the time to understand and listen to the problem. And by doing that, it gives us ample amount of opportunities to not just understand our patients, but more importantly, provide the best solution, because we listened to the reason why there is a problem. It's something that we take very seriously, and it just only makes patients happier, and then they tell everybody about it. So our methodology is really simple. We take the time to listen. We take the time to accurately put the pieces together to diagnose and also treat. So a very typical day will consist of a new patient visit or a follow-up visit, or in a few scenarios, we would have like a diagnostic visit where we're maybe trying to diagnose where the pain's coming from. And another type of visit we also have would be performing the procedures to actually treat the pain, eliminate the pain, and then just go on from there.